Hi, this is Roger Green, executive producer and host of the Surfing the Mesh Tsunami podcast. This week, over the holiday week, we will be sharing 5 conversations from episode 27, our coverage of last month's Deliver Meeting 2024. This conversation focuses on 2 or 3 sets of issues, all related to patients in one way or another. It starts with me asking the group whether the presence of 2 approved MASH medications that do not require biopsy to start therapy will make it more challenging to recruit patients into clinical trials that require 2 biopsies and where some patients might receive placebo. The group says that this will not be a significant challenge, that they've been working with these kinds of issues already and they're confident. We then go on to discuss some of the papers at the conference that talked about patients. Naim Alkhouri mentions the first 2. First, a paper discussing this value of synergy between resmetirom and the GLP-1 agonists. And second, a paper that was presented by Arun Sanyal in the Late Breaker, taking a look at different genetic polymorphisms and predicting the impact of tirzepatide on specific patients. Dr. Sanyal's paper noted that the G allele, which is found more frequently in some patient groups than others, and in the U.S. notably more frequently in Hispanics, may have an independent effect on the disease beyond what we find from weight loss and exercise. Michelle Long goes on to mention a recent paper in Nature identifying distinct clusters of patients based on how their SLD progresses over time. And in this one, I identified the challenge posed by lean MASH, since lean patients tend to progress faster and, as we've said on the podcast over the years, might have greater economic consequences for the payers. As you listen, you'll hear all of our enthusiasm, which was infectious within ourselves, and we hope to those of you who are listening to this episode. The one question it left me with is, as long as FDA requires biopsy, when you've got 2 available agents that you can treat with and insurers generally will not require biopsy, how much more difficult will this make it to get patients into and keep patients in clinical trials? And what has to be done about that? Now, that's not for today, but the patients and patient advocates I've talked to all see that as a very real issue. We had some fantastic phase 2B results, but all those have to get translated to phase 3s before they can get to market, which means we have to get people into studies. And as long as we don't have a reference agent and we've got biopsy, which means the control group has to be a biopsy placebo group, that feels a little challenging to me. Without digressing much, I'd love to hear thoughts from any of the scientists about what's being done to deal with that or how big a problem you think it'll be, and then maybe comments from the patients, and then we'll just go on.
Naim Alkhouri.
I mean, it is a concern, as you said, Roger, because we want to get to the finish line with different agents. But I think having the GLP-1s and dual agonists on the market for obesity and type 2 diabetes have caused delays already in clinical trials. I mean, there's no denying this. Most clinical trials require that you are steady on these medicines for about 90 days at least before you can be enrolled in a trial. And then you cannot be in the active weight loss phase. You have to be steady. Having said that, in the Maestro NASH, we had about 15% of patients that were on a GLP-1 and still had F2, F3 on biopsy. I'm looking at the prescriptions we do now for resmetirom in our clinics, and we have about 424 patients that we collected data on at a few academic centers in the US, and about 23% are on a GLP-1, yet they still have F2, F3. I think we offer, of course, resmetirom to all the patients we see that might be candidates for trials, and sometimes they select to go on the medicine. But now the clinical trials also are thinking about allowing patients to be on resmetirom, stable dose for about 6 months, and then they can be enrolled. So yeah, we will see some delays, but I think, the size of the pie, as Michael said, is very big. And I think, we've had several agents for diabetes for decades now, and we still do diabetes clinical trials. So it may change the dynamics, but I'm confident that we will make it to the finish line with the current medications we have in phase 3.
Jörn Schattenberg.
I agree with Naim, and with the ex-US perspective, we have no approved drug at this point. And I think there are countries in the world where the GLP-1 uptake is clearly slower too. And we really want to treat this disease globally too. So I think there's more opportunities, and drug developers just have to be smart and move this forward and, allow certain co-medications, I think. And this will be a plastic field changing according to approvals.
Michelle Long.
No, I fully agree with all of that as well. I think that, like you said, Naim, I mean, there's definitely, much room for improvement as well. So I think that especially when patients are meeting those NIT criteria, despite being on GLP-1, and if you're allowed into a phase 3 program of stable background therapy and you're meeting NIT criteria for disease or histology criteria for disease, then it makes sense that, you potentially want to have something else to address your disease burden. So there's certainly a lot of room for innovation here that we really need to keep pushing forward. One of the things that I worry about is that I want it's really important that people actually do go through with the risk stratification and try and find these patients, because you don't want people to say, I don't want people to say, okay, this drug or these class of drugs appear to have multiple indications. Maybe they also work for liver disease. It's not approved yet, but who knows? And they start using it without actually doing that risk stratification step, because you need to know who needs something else or who needs something more or who needs to be followed more carefully. So I think that's a big vulnerability I see now that just speaks to the education needs and the needs to make these pathways simpler, more intuitive, more able to be scaled on a global basis. So there's a big challenge ahead, I think, on that front as well.
Mike, Jeff, where do you see patients on this?
Mike Betel.
I don't know how much more I can add, but to say that this is nothing but an opportunity for patients moving forward. And, but with regard to the studies and any challenges, I mean, Roger, you said at the beginning, it's possible that if patients in clinical studies still have to do a biopsy, but outside clinical studies, because they can get an approved drug, don't have to have a biopsy, it might not be as enticing for them to be in a clinical study. That's, I think, where you started to get to before, right?
Yeah.
Jeff McIntyre.
I'll add that I don't think we're talking about huge numbers here. And if we were to take a look at the hesitations around enrollment in a clinical trial, this is just one of the factors. And so I don't know at what point the hesitation becomes no hesitation, because this doesn't exist in a vacuum, if you will. There's so many other hesitations that would feed into hesitation around there being another possible medication or therapy available that a patient could get into. We still have a ways to go to that. I think biopsy is going to be much more of an issue immediately in this. And from a patient advocacy standpoint, we promote clinical trials as healthcare. And to Michelle's point, I think there has to be this risk stratification, because we just simply don't have the people in the system to kind of know what we're picking and choosing from on this. And so, yeah, it's probably going to be an issue. We hear it from our patients and we talk about that, but it is one issue among many. And for it to suddenly become the priority that we rest patient involvement in clinical trials on, I think would be a false presumption to make. It's important and it's kind of in the conversation, but I think there's so many other areas and so many other things that patients really would look to clinical trials for that could be attractive to clinical trials for, other than this kind of bump in the road. And if anything, I think it can be, an educational opportunity for us to be able to talk about different medications, about their impacts, about even potentially combination therapies, as we go for this as well. So it's a bump. It's not a mountain.
So now that you folks have done such a good job of collectively being the wind that blows the one cloud out of the blue sky, why don't we go back to what else makes the sun shine so brightly? Naim, you're good. Who wants to go next?
I'll follow up on, the Essence trial. There was a lot of data presented from the Maestro-NASH trial, including one study looking at the response rate in patients that were treated with resmetirom, whether they're on a baseline GLP-1 or not, showing a pretty much similar response on the MASH resolution rate and fibrosis improvement rate. So that speaks to the potential synergy, and that, you're going to get whatever benefit you get from your GLP-1. But once you're on a steady dose and you're not losing weight actively, and if you still have F2, F3, being on a GLP-1 did not affect the response to resmetirom. So I see this as potential for synergy. Of course, when we talk about synergy, it's not just, the additive effect. So we hope that, maybe utilizing the two medications, especially if we do it sequentially within 6 to 12 months, that will lead to maybe higher rates of MASH resolution and fibrosis regression. So more to come on this. We saw several studies looking at the effects of baseline polymorphisms in several genes like PNPLA3, HSD17 beta. It seems like polymorphisms in PNPLA3 did not affect response to resmetirom, but there was one study with tirzepatide that potentially having kind of like the bad genotype may affect the rates of MASH resolution. And I don't know if we get to a point of personalized medicine where we start doing this routinely in our patients in clinic, and that will help us select the best treatment option. As you guys know, there are several companies developing targeted therapies for these genetic polymorphisms. AstraZeneca, GSK, for example, they target PNPLA3, HSD17 beta, Regeneron. They have have a program and other companies. So we do the testing in these trials before we actually enroll these patients in the trials. But I can tell you that we don't do this in the US routinely. However, it's pretty cheap now and it can be done. So I think, this is something that may become part of the routine standard of care, that we do baseline testing for PNPLA3, HSD 17 beta 13, and maybe some other polymorphisms.
That was interesting. If we pause here for a second, Naim, I think this was particularly interesting because tirzepatide is thought to be a pretty potent drug, and not all patients showing maximum response. Looking from the patient perspective, however, this is something you cannot change in a patient. So it probably be not the decision to not treat him based on his genotype unless we see other drug alternatives that are really focusing on that and that might be exceeding the potency there. So I find it's interesting also to understand why some patients respond different to others.
Yeah, I do believe that we should start doing this routinely in all clinical trials and then risk stratify based on these, just so we understand. And it could be mechanism of action dependent, and I absolutely agree. It only becomes relevant when you have multiple options. Otherwise, it would not be fair to not treat someone based on a genotype.
Yeah, I don't know if you guys saw this paper that came out earlier, like in December. It was published online in Nature Medicine. This was a paper looking at different clusters of distinct phenotypes and of MASLD to see if there are potentially different groups that you can describe patients. And there was this cluster that came out they were younger, they had high ALT, and they also had a much higher proportion with this less favorable genotype of PNPLA3. And they also then were able to look at long-term outcomes. This is Stefano Romaro and others put out this paper. They had less risk of CV outcomes, diabetes and things like that compared to the more typical metabolic cluster. So, it'll be really interesting to see how that emerges over time. If there are groups that have different risks, perhaps you might want to treat them differently. I don't know, but I agree with you both that probably if you have risk factors, then there's probably good reason to sort of address those, but it might be that this population needs something else, or you need to look more carefully because they were younger age and they were having the same risk of liver-related outcomes as this much older, much more metabolically sick cluster. So I thought that was quite interesting.
I agree. I thought the combination of that paper and the paper presented on tirzepatide and PNPLA3 at Liver Meeting painted an interesting picture. I've kind of believed forever that lean NASH should get more attention than it gets because the economics are worse and it happens faster. And I think the Romeo paper addressed that to some degree. What I thought was interesting from a societal or demographic perspective is that the tirzepatide paper pointed out that they found the G allele that causes a problem independent of metabolic disproportionately in Hispanic patients. And given the volume given how many Hispanics in the U.S. there are and the proportion of patients they make up with this disease, we might want to think about how we treat or diagnose them or manage them somehow differently based on the idea that there might be more than just metabolic going on.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Over the rest of the holiday, we'll be sharing conversations from episode 25, in which Maru Ranella went over expert recommendations on use of resmetirom, and also a conversation Jörn and I recorded with Scott Freeman last summer that never made it to air. Plenty to listen to while you're at home and away. And we'll be back in January covering MASH-TAG and then moving into our new 2025 Surfing MASH V2.0 format. Take care, stay safe, surf on. We'll see you on the podcast. Bye-bye now.